Hello and welcome. Today, we're diving into a condition affecting the urinary system called vesicoureteral reflux, or VUR for short. This occurs when urine flows backward from the bladder into the ureters, and sometimes even into the kidneys. It's more common in children but can affect adults as well. Understanding VUR is crucial for protecting kidney health, so let's explore the details. What causes this backward flow? In most cases, primary VUR is due to a congenital defect, meaning a condition present at birth in the vesicoureteral junction, the point where the ureter connects to the bladder. Ideally, this junction acts like a one-way valve, preventing backflow. In VUR, this valve is either too short or improperly formed. Secondary VUR, on the other hand, develops later in life due to an obstruction or blockage in the urinary tract. This can be caused things like an enlarged prostate in men, scar tissue from previous surgery, or even nerve damage affecting bladder function. Let's talk about how VUR actually affects the body. When urine flows backward, it can introduce bacteria from the bladder into the ureters and kidneys. This contaminated urine can lead to urinary tract infections, or UTIs. Repeated UTIs and the back pressure of urine can damage the kidneys over time, potentially leading to scarring. This kidney scarring, known as renal scarring, can impair kidney function and, in severe cases, contribute to high blood pressure or even kidney failure. Vesicoureteral reflux is most commonly diagnosed in infants and young children, often after they've experienced recurrent UTIs. Studies suggest that it affects around 1 to 3% of children. While it's less common in adults, those who had VUR as children may still experience complications. There is some evidence of a genetic component, meaning that children with a parent or sibling who had VUR are more likely to develop it themselves. The signs and symptoms of VUR can vary depending on its severity and the presence of a UT. Many children with mild VUR have no noticeable symptoms. However, the most common symptom is recurrent urinary tract infections. These infections can cause symptoms like fever, frequent urination, painful urination, abdominal pain, and flank pain, which is pain in the side or back. In severe cases, VUR can lead to high blood pressure or signs of kidney dysfunction, such as swelling in the legs or ankles. Diagnosing VUR usually involves a combination of tests. A urinalysis can detect the presence of bacteria in the urine, suggesting a UTI. An ultrasound of the kidneys and bladder can identify any structural abnormalities. The gold standard for diagnosing VUR is avoiding cystoarthrogram, or VCUG. In this test, a catheter is inserted into the bladder, and a contrast dye is used to visualize the bladder and ureters during urination. This allows doctors to see if urine is flowing backward into the ureters. VUR is classified into grades, ranging from I to V, based on how far up the ureter the urine flows and the degree of dilation, or widening, of the ureter and kidney. Grade I is the mildest form, where urine only refluxes into the ureter. Grade V is the most severe, with significant dilation of the ureter and kidney. The grade of VUR helps determine the best course of treatment. Treatment for VUR depends on the grade of reflux, the child's age, and the presence of recurrent UTIs. Mild VUR, grades I and II, often resolves on its own with time, especially in younger children. In these cases, a wait-and-see approach is often adopted, with close monitoring and prophylactic antibiotics to prevent UTIs. More severe VUR, grades SU to V, may require surgical intervention. Surgery involves reimplanting the ureter into the bladder in a way that creates a better one-way valve. This can be done through open surgery or minimally invasive techniques. Antibiotics are also used to prevent UTIs in these patients. While it's not always possible to prevent VUR, there are steps that can be taken to minimize the risk of complications. Prompt treatment of UTIs is essential. In children with a family history of VUR, screening may be recommended to identify the condition early. Ensuring good hygiene practices, such as proper wiping after using the bathroom, can help prevent UTIs. For individuals with secondary VUR, addressing the underlying cause, such as an enlarged prostate or bladder dysfunction, is crucial. The prognosis for VUR is generally good, especially with early diagnosis and treatment. Many children with mild VUR outgrow the condition. With appropriate management, the risk of kidney damage is significantly reduced. Recent research is focusing on less invasive surgical techniques and better understanding the genetic factors involved in VUR. Ongoing studies are exploring new ways to prevent UTIs and minimize the long-term effects of VUR on kidney health. It is important to have regular follow-up with a healthcare professional to monitor kidney function and ensure the best possible outcome.